Hi, I'm Grace Halsey, Senior Editor at Patient Care Online, a website for primary care physicians. And our clinical focus this month is on preventive cardiology and the role of primary care provider in, so we're off to a good start. And the role of primary care provider in reducing the risk for cardiovascular disease. And this morning I'm talking with Dr. Seth Baum, specifically about ASCVD risk prevention, and which is really the foundation of primary prevention. A little bit about Dr. Baum. He is the clinical affiliate professor of biomedical science in the Department of Integrated Medical Sciences at Florida Atlantic University's Charles E. Schmidt College of Medicine, and founder and chief medical officer of Excel Medical Clinical Trials, LLC. He's past president of the American Society for Preventive Cardiology and is in private practice in Boca Raton, where he solely focuses on lipidology and cardiovascular risk prevention. Good morning, Dr. Baum.
Good morning. Nice to be here.
So I want to start this morning with asking you to talk about the state of ASCVD risk assessment in the United States in 2020. And in the last 2 years, in 2018 and 19, the American Heart Association and American College of Cardiology put out 2 sets of updated guidelines, one on the management of blood cholesterol and the other one on primary prevention. And so my question is, that puts a lot of evidence-based information into circulation, pardon the pun. So how are we doing? What is the state of our foundation in terms of assessment?
Yeah, well, that's a good question. You know, as I watch you and hear you ask that question and talk and refer specifically to 2020, unfortunately, 2020 is not 2019 in that we have COVID. So if you ask about 2020 specifically, the state of prevention is, I would say, terrible, okay? So let's go back because of COVID, solely and strictly because of COVID. So let's go back to 2019, and then we can move forward again to 2020 and discuss some of the problems we're having and how clinicians can address those problems and improve cardiovascular risk reduction, right? So ACC/AHA did in 2018 come out with these very, solid guidelines. But first I'll take part of the problem. Part of the problem is they're really long, okay, as guidelines typically are. To address that, there are specific algorithms and charts showing us, how to address certain issues, but still they're complex. But I think the important thing is to take away some meaningful messages that can help us manage risk, reduce risk, and therefore reduce the risk of cardiovascular events. The goal ultimately, of course, is to decrease heart attack, decrease stroke, decrease cardiovascular death, decrease hospitalizations for acute coronary syndrome, decrease heart failure, etc. So that's the ultimate goal. So how do we get there? Well, one of the things that's emphasized is that LDL cholesterol is now understood to cause vascular disease. And I know that sounds simplistic, but I'm going to just repeat it because it's really, really important. A lot of people don't really know this at this point. LDL causes vascular disease. It's not just associated with it. In other words, when you have a high LDL, it's not just you're also likely to develop heart attack or stroke or cardiovascular death. It's that it's causing that. So we need to address LDL very aggressively. We need to lower it very significantly. And we need to approach patients according to their risk. So the highest risk patients, we address LDL most significantly. The lower risk patients, we address it, but it's not quite as okay. So that's one thing. So these are overarching things. We can get into some numbers in a moment, but those are overarching ideas. Another very important finding or statement within the guidelines is that we don't know a lower LDL bound. There's no boundary that we've really established saying, oh my God, that's just too low. We need to back off the medicine and get the LDL higher. And in further support of that, we have guidelines from ACE, the American Association of Clinical Endocrinologists, as well as the European guidelines, which came out in 2019 after our guidelines, and even more aggressively lower LDL and explicitly state the causation that LDL has with regard to vascular disease. They go really far. They say it causes it, get LDL as low as possible. And by the way, if somebody's has had a recurrent event on your maximal therapy that you put them on, get their LDL even lower, under 40. 40 becomes the goal, all right, in some of these patients. So although we have a target of 70 for our very high risk patients, they have a goal of under 40. So I think, it's very hard to remember, well, if a patient has two major risk factors and one minor, or two minors and one major, people just, when you have 30 patients a day, or some people see 50 patients a day, you're not going to be able to do that. So you need to know the general idea. The general idea is LDL is bad. It causes vascular disease. We have tools to fix that. The first line, so we'll get specific here, is statins. Always go with statins first. Try to maximize statin dose if you can. Understand, however, that even though we say, have highest dose statins for certain conditions, such as very high risk patients, lower dose is okay if they can't tolerate it. You can always add on other agents like ezetimibe or the PCSK9 inhibitors. So don't ignore a statin just because the patient can't tolerate the highest dose of a statin. Go to a lower dose and go to the maximally tolerated dose of a statin. So that really is how we should approach lipid management in cardiovascular disease prevention. We separate out also primary prevention and secondary prevention. And primary prevention means somebody who has not yet had an event. How do we prevent that event? Secondary prevention, if you've had an event, how do we prevent the next event? Well, from a secondary prevention standpoint, we have to remember these people are at very high risk for a next event. And if somebody's had two or more events, they're at even higher risk for another event. So we are most aggressive with them. Going back to primary prevention, they haven't had an event. We need to look at what their risk is for an event. We need to do the equation, the pooled cohort equation, and take a look and what's their 10-year risk. And if they're a little bit younger, what's their lifetime risk? So their 10-year risk may not be that high, but if their lifetime risk is high, you got to be more aggressive. So we risk assess them. And all that's doing is looking at certain features like what's their LDL, well, do they have diabetes? Do they not have diabetes? Sometimes we look at a calcium score to see whether they have risk, or Lp(a), which is another very bad player in lipoproteins. So these are the things that we're looking at.